Good evening, everyone. How are you all? All right, so let's start our tonight's session. Again, welcome to First Aid AMC. And I am Dr. Arshan. Most of you already know me because we had our first session on 15th of June, right? And we started with Psychiatry MSE theory session. And many of you might not attend that class. So for those of you, I am Dr. Arshan, and I will be mainly your First Aid AMC clinical course mentor. And also there will be a few other doctors who will be also acting as a mentor in your course. So mainly today we are going to focus on how to do appropriate role play. And we are mainly trying to do some role play based on the theory session that we had last week. Not last week, last fortnight, right? So I guess that many of you has joined that session. For those of you who did not, please make sure that even before this class, if you really need to understand how to take the history properly, especially on a psychosocial history, you have to go through that class first, because we discussed everything, ins and out of every possible psychosocial history. All good. So let's start with the role play. Now, tonight, we would not do any of the theory things that we have done already. We would mainly see that how you guys are doing with the role play. And obviously, I will be here to guide you throughout the session, that if there is anything that you are missing, or if there is anything that you need to improve, I will try my best to show that to you and help you to improve that thing. So any of you are all right to come forward and do the role play. Even if you are a beginner, there is nothing wrong with that. This is how you gain confidence. Initially, you will feel in your head like, well, I don't know anything. I have never done any role play like that in my life. What if other people think something bad about me? The first thing is that no one knows you here, mostly. And if you're worried about your name, you can change your name to something. Okay, that's fine. I'm happy with that. But you need to do the role play when you are joining the session. And that's how you gain confidence. You gain the strength in your voice. That is what you need as the first and foremost thing for appearing clinical exam. When an examiner comes across a student or a candidate, the voice of that candidate will show that how much confident that person is. And just during that time, examiner already knows in their head that are they going to pass this candidate or not. So sometimes you can be just totally marked as fail in the examiner head if you are not confident in your voice, if you are not confident in your gesture. So those things you need to gain with these role play sessions. And the good thing is that this is a 5-month course that you're going to have in front. And throughout the 5 months course, you will end up getting a lot of role play. We have role play sessions on theory, just like how we are doing today. We will have role play sessions every week based on some important cases that is so important for your exam. So you will see other candidates how they are doing role play. Also, in our role play session, we allow our previous batch students, and they can also do the role play with us. And in that way, what happens is that previous students already, they are doing role play with us for months and months. They are very much improved. And you listen to them and you learn from them as well. So that's how these things works actually, that it's not always you're just learning from me. You will learn from others also. You will pick up like a little phrase from others, and you will use that in your own approach. And that's the interactive learning that we are going to do throughout the course. All right. So obviously, I can see a little bit of you are still in Facebook. So if you come across to the Zoom session, that will be the best, because then you can also do role play with us. We can't do role play on Facebook. So if you want to do role play, you have to join the Zoom sessions. Okay. So enough chit chat. Let's start with the role play. Okay. So who wants to go first? And always I would advise for someone who hasn't done role play previously, try to come forward so that we can find out new people. We can find out a new person who is doing role play with us, and that person is also gaining the confidence. Okay, is Dr. Brad, did you do role play in the previous session? I think that one, the delirium case. Yes. Okay. I will just skip you today. We will see someone new. And obviously, if no one wants to do it, then you will be my first priority. All right. So after Dr. Brad, then there is Dr. Gayatri. So yes, let's do with Dr. Gayatri. I will just unmute you.
Hello.
And just let me know if you can hear me. Yes, Dr. Gayatri, can you hear me?
Yes, doctor, I can hear you.
Great. Okay. Let me give you the case. Just a second. Okay, so you will get 1 minute outside and then 7.5 minutes inside to finish the case. Now, because these are AMC role play sessions, you will not be able to think anything in your head. So if you are ready, just let me know. Okay, so this is your case. Your 1 minute time just started.
Okay. Yes, doctor, I'm ready to start.
Okay. Right, so this is your patient. Your patient name is James. You can start.
I am Dr. Gayatri. I'm one of the GPs working here, and I'm going to look
Yes,
after you
President.
today.
Yes, I'm coming. Yeah,
Oh.
yeah, President. Yeah, just hang on a second. Yeah, I've got some doctor in here just to talk to me. I'm just coming in a minute. Please excuse me, President.
Yes, James. I'm here to help you out. And first of all, I want to mention the confidentiality. Whatever you mention, it will remain confidential only between you and me, unless there is a threat to anyone
Yes, sir.
else.
Yes, sir. Yes, I understand. This is very important, sir. Yes, it's just like I've got caught into something. I'm very sorry, sir. Yes, I know the urgency of it. The war is coming, and you need me for it. It is important. I understand, and I'll be there. I'll be there. There is no one who can actually be without me. The war is coming. I understand, sir.
Yeah.
Yes, sir.
Yes, James, can you tell
Sir,
me like
yes,
whether
yes.
you are able to see anyone or you are able to hear anyone's voices?
Sorry, who are you?
I'm Dr. Gayatri. I'm here to help you out. So can you tell me like
all right, with due respect, doctor, I don't have this much time in my hand. The world is going to end. So please excuse me. I just need to catch the flight now because the president is waiting for me.
Yes, I totally understand your concern, James. But we are here to help you out. I'll just ask just few questions.
I don't need any help. The world needs help, doctor. Just understand that the world needs help. I don't need help because I'm only one who can save your world. So just let me go and save your world.
Yes. And are you hearing these from? Are you able to see them as well?
No, they don't come. The president is a very important, powerful person. He doesn't come to show me.
Yes, yes. And also, are you able to feel them?
What does it mean? How
Like,
I can feel someone?
yes, yeah, I can totally understand, James. And can you tell me, like, what are they commanding to you?
They are not commanding anything to me. They're just asking me to save this world because I have that power. I have the power of Harry Potter, and they believe that I'm the only one. I'm the chosen one who can save this world. So that's why I'm
Yes,
saying to you that let me go because my flight is just going in 15 minutes.
yes, yes, James. I can totally understand your urgency. So can you tell me about your mood, James? How is it?
I don't know. It's just like I can't think about my mood because I'm here for a greater purpose. This is not about me, doctor. Let's try to
Yes,
understand.
yes, James. Yes, and also, can you tell me about your sleep? Has it been affected?
There is no time for sleeping in this time. I have been
Yes.
planning to save the world for months. So this is I can't sleep just for this.
Yes, I can understand. And do you have any difficulties like while initiating the sleep or while after you get up, awakening in the sleep?
I don't care, doctor. This sleeping things, I don't care.
Yes.
I
Do you
just need
have
to save
any?
this.
I understand, James. Do you have any nightmares or any flashbacks?
No,
Okay. And James, I know when people are under stress, they try to harm themselves or others. Do you have any thoughts as such?
no, doctor. Are you hearing me, doctor? I'm trying to save the world. Why I'm going to harm someone?
Yes, 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 James. And also, I'm going to ask a hypothetical question. If there's a fire in this room, what will you do?
The fire can't touch me. I have the power to do anything.
Yes, yes, James. And also, do you know where you are at the moment?
Yes, I'm in the hospital.
Okay. And do you know to whom you're talking to?
Yes, doctor.
Okay. And James, do you have any? Do you think that any of your thoughts have been inserted into your mind?
No, no one can do that.
Yes. And also, do you think that people are talking about you?
Yes, a lot of people talk about me because they just want to have my power. They just think
Yeah.
that like they are a simple person. They are not special like me.
Yes. And also, do you think that they are jealous about you as well?
Yes, obviously. They are
Yeah.
jealous about me.
Okay. And do you think your thoughts have been broadcasted into the public, into the into the TV or any broadcasting media?
No, my mind is like a wall. No one can penetrate that.
Yes, James. And also, can you tell me like that you? I understand from my notes that you have been diagnosed with schizophrenia disorder. So, since when have you been diagnosed?
What is that? I don't know what this disorder is. I was totally fine. I'm fine.
Yeah, okay. And have you been on any medications, James? Any
Yeah,
any
some
medicine?
doctor wanted to put me on medication. I just had some of those for a few weeks and then just stopped it.
Okay. And can you tell me, James, why did you want to stop the medication? What was the reason?
Because I'm fine. Why I will need medication?
Okay. Yes. And also, do you still experience any other, any other symptoms like other than this?
What symptoms?
Yes, like you're still having any, do you feel any other person other than this? Like, as you said, you feel you was able to see and hear your president. Were you able to see any other people as similarly like that?
No, I can't see anyone. There is no,
Okay,
I can't see
yeah.
anyone. It's just like I need to go to the president because he needs me. That's the only thing.
Yes. And James, can you tell me about did anything change recently that anything triggered you for you which had changed recently?
No, nothing.
Okay. And James, how is your home situation? Do you have enough support from your family?
I don't live with anyone. I just live alone.
Live alone. Okay. And also, do you have any, like, how's your academic performance?
Who cares about academic performance? I am special and I don't need these grades.
Yes, yes, James. I totally understand that. And also, do you have any trouble with any finances?
No, I have power to do anything. I'm
Okay,
up.
James. Yes. And just few last questions. Do you smoke or do you
I'm up.
drink alcohol? Okay. Yes. Thank you very much for answering my questions, James. I'm going to please excuse me to present my MSc to the examiner. So we have a patient who had been presented with previously schizophreniform disorder, but he didn't take the medication, and his MSc, his mood appears to be mood appears to be quite stable, and it is incongruent with the effect. And I couldn't assess his appearance and his appearance and his eye contact, and also his thoughts seems to be quite flight of ideas, and also he was positive for having visual and having auditory hallucinations, and he had some delusion of grandiosity and delusion of jealousy as well. And also he seems to have lack of insight and lack of judgment, and also lack of his cognition seems to be intact, and also he seems to his history seems to be quite unreliable. I would like to take another reliable history from the bystanders and others, and he seems to be having moderate to severe risk to himself and others because of his active delusions and hallucinations. So my most likely diagnosis is it could be due to schizophreniform relapse, it could be due to schizophrenia, and it could be due to schizoaffective disorder, it could be due to drug-induced psychosis, and it could be due to any other bipolar affective disorder, and it could be due to even some organic disorders like any head injuries or even a thyroid thyroid changes as such. Thank you.
Dr. Gayatri, he did good. All right, so it was really
Okay.
good. The timing was not perfect in my
Yes.
view because it took about, let's say, 10 minutes or 9 minutes and half second
Okay.
for the whole case. So the
Yes.
other thing is important because I let you to continue, but always remember in exam, if your time is up, you can't talk more than that.
Yes.
You just stop there because
Yes.
there will be other candidates who are waiting on the other end of the door to finish your exam and starting their exam. So the basic thing is that anything like face to face or online, when your time is up, it is up. There is nothing you can do. All right. But in face to face, sometimes we say that if you missed a very specific, very important thing, even if there is the ring is like if the ring is bell, then you can just say that and then like you get up from the chair and you just say it and get out of the room. Okay, so that you can
Yes.
do, but for online exam you can't do anything. When time is up, it is up. Okay,
Yes. Thank you,
and
doctor.
other than that, you did great. You were calm throughout the session, which is very important. All right, because getting your nerve calming down is very, very hard in these cases because they're actually trying to do that, trying to make sure that you get confused. And you always have a format in your head which the role player is supposed to break by interrupting you multiple times, by asking some stupid questions towards you so that you just get confused. And that's what they want to do. So having that calmness in yourself, that is so important, which you had actually, that is really good. Now, apart from that, I think like you did great. So you asked most of the important questions, like you try to rule out hallucination, you asked all the delusion question. Okay, you can always ask some of the other delusional question. If you know that this is a schizophrenic case, always ask the full RCGGP question, which means ask about like, do you think anyone is trying to harm you or is spying on you? That's to rule out paranoid delusion. You asked directly about jealousy, that is all right. You already knew that patient having delusion of grandiosity. You can always ask about, you asked about thought broadcasting, thought insertion, thought withdrawal. Those were good. All right. Other thing I would say that because you already know this patient had a schizophreniform disorder previously, yes, it is important to ask about that, which you did, and obviously ask about, did you take any medication, how long you took it, and are you taking medication? To say no, then you ask the patient that, is there any particular reason why you are not taking that? And patient will say, yes, I just don't feel like I need to take it because I'm fine. So those are the findings that you will get. And obviously, one other thing, we always need to rule out drug-induced psychosis in these cases because differential is one of your tasks. So in this case, make sure that you ask the patient that, do you smoke or drink alcohol? Is there any other recreational drugs that you use? If yes, then like, when was the last time you used that? Because that might be just the case. In case that you don't get any drug-induced thing or any other positive finding, then your most likely diagnosis will be relapse of schizophreniform disorder. Now, the very important thing among everything is the duration of illness, which you did not ask. It's a very important thing because your diagnosis depends on that. Because now, if the patient having the symptoms just for 3 months, then it will be again a relapse of schizophreniform disorder. If the symptoms persisting more than 6 months, the diagnosis will be schizophrenia. So we need to always ask that, like, very important, any psychiatric history, ask the patient how long you are having this, how long you are feeling like this. That is also very important. So differential will be, let's say, it can be just a new onset of schizophrenia. It can be drug-induced psychosis. It could be bipolar affective disorder. It could be schizoaffective disorder. It could be, let's say, sometimes any other substance abuse disorder. Okay. So those will be our main differential diagnosis in here. Either it's a relapse or new onset, then drug-induced psychosis. Then we thought about bipolar affective disorder or even a mania case. Now, in case of MSE presentation, so follow the format always. So you'd say that you can't see the patient. That's all right. So appearance you could not assess. Then after that we have S, right? So S for speech. So his speech was normal in tone, volume. So you can always say that the speech was like, I would not say that his speech was like very loud or pressured one. You will know which one is pressured speech. So when we will do the role play today, but this speech, you can say it was normal in tone, volume, and quality. You can also say that there is no pressured speech. There is no loosening of associations. Okay, those kind of things you can say. Not loosening of association, you can say there is no disorganized speech. There is no rapid pressured speech. So that will be your speech thing. E for emotion. In emotion, we need to say that what was the mood of the patient. If patient say, I don't know, you will say, in terms of emotion, my patient told that his mood, like he did not know about his mood. Or you can say that in terms of emotion, my patient did not comment on his mood. But the affect that I have observed was disturbed. So that will be our way of saying that. Okay. After emotion, we have perception. This patient had a auditory hallucination, no visual or tactile hallucination. Thought form, you missed the thought form. So thought form was linear because you could understand the patient. If you understand what patient is saying, thought form is normal, which is linear thought form. And then there was no flight of ideas. There was no loosening of association in here. Okay, flight of ideas means patient will just jump from one topic to another topic. But in this case, the topic was just one thing, saving the world, talking to the president, those kind of things. So no flight of ideas. Okay, thought content. What were the thought content in this case? Guys? Delusion of grandiosity. Yes, Dr. Rashid, very good. Delusion of jealousy, we can say. And yes, delusion of reference, because people are always commenting on me. People are always talking about me. So those will be our main delusion in here. Delusion of reference, delusion of jealousy or persecution, and also delusion of grandiosity. After thought content, insight was lost, cognition was intact, judgment was poor. Then we have 3R: risk, rapport, and reliability. Obviously, this patient is a moderate to high risk patient because of active hallucination and delusion. Yes, you were able to maintain a good rapport with the patient, and this history is not reliable. So you would like to take a collateral history from either from the university or maybe from from where the patient lives. So anyone who is living with the patient, you can take a collateral history from them, or maybe even the school counselor. So that should be fine. So that's actually all about this case. Is there any question, guys? All good. So let's start with another role play then. So who is going to do the next role play? So the difference between schizoaffective and schizophrenia is that schizophrenia patient only will have psychotic features, which means hallucination, delusion, disorganized behavior or speech, and that has to persist for at least 6 months. Now, in case of schizoaffective disorder, which means that patient has schizophrenia symptom as well as affective disorder symptom. So when a patient has both psychotic feature like hallucination, delusion, disorganized behavior, with that patient having either mania or depression. So when both of these are there, then only we call it as a schizoaffective disorder. So J stand for judgment. So insight, cognition, and judgment. So it would be a good idea, like if any of you who haven't done our theory session, this class might be a little confusing for you because everything that we have done, it's already been discussed in our previous session. We are just practicing it. So make sure that if you haven't done our previous session, do that first because that's the way to learn about this. That's why I'm not discussing too much about these things because it has been discussed in a detailed way. Okay. Now, this is a good thing. Like if you see that if a patient having, if your STEM says diagnosis and differential diagnosis, yes, you have to ask some questions to rule out differential diagnosis. So actually, Dr. Gayatri asked many of those because she asked about, let's say, is there anything that happened recently? So that adjustment disorder. She also asked about, she could not ask about the drug thing, but she asked about smoking alcohol. So drug, we just need to ask about any recreational drug use. Sometimes when you ask that, how is your mood these days? If patient says high or low, you can always ask the opposite thing. Like if patient says, I'm feeling very low, we ask the patient, is there any time that you feel very high? That will rule out possibility of bipolar disorder. All right. So That's actually the differential questions. Not much to ask in here because you'll be running out of time. Usually in these cases, 4 to 5 differentials are fine. So mainly all of your psychosocial history is covering the differentials already, because schizophrenia, schizophreniform disorder, schizoaffective disorder, those are getting covered with your psychiatric history. Same with drug-induced psychosis, covered. Then we have your bipolar, covered by mood question. And then what? We have adjustment disorder. We just ask the question, anytime do you feel like, is there anything particularly happened recently? So that you usually get covered with all the differential just with the format that you have learned. Okay, so nothing much to add. Apart from, you can just ask organic questions, which means any recent head injury, any flu-like illness, is there any change in your weather preference? Weather preference for thyroid disorder, head injury, and flu-like illness to rule out any possible organic disorder which can mimic some psychiatric illness. So that should be all. You don't need to add much more than what is already given to your format. Yes, Dr. Faisal, you can do it. So let me just unmute you.
Hello.
Yes. All right.
Hello,
I'm
doctor.
giving you
Can you
the
hear me?
Dr. Faisal. Yes, I can hear you.
Thank you.
All right. Just give me a minute. I will give you the case. Okay.
Sure.
All right. So this is your case. Your 1 minute time just started.
Okay.
Okay. So your patient name is John. You can start.
Hello, this is Dr. Faisal. I am one of the doctor here. How can I address you?
Yes. It's John.
Oh, John, very nice to meet you. This is your doctor here today, and I'll be here to help you. So today, whatever we will discuss, it will be among you and me until it cause any harm to you or others. Is that all right?
Yeah. Yeah. Sure.
Oh, John, can you please tell me what brought you here today?
It's nothing.
Okay. So how are you feeling nowadays? How is your mood?
It's just very hard.
I see. I'm so sorry to hear that, and I'm really feeling very sorry. Uh, John, do you see, feel, or feel anything which others don't around you?
I can I can hear those voices. Everyone everyone is saying that I'm a martyr. I killed that patient. Hello? You guys can hear me? Yeah. Okay. What happened to Dr. Faisal? I can't hear him. Yeah, I can see that he's on mute. I'm trying to unmute him.
Hello?
Yeah, what happened? You muted yourself? Dr. Faisal, I can't hear you. Can you unmute yourself? You should be able to do it by yourself now.
Yeah, I'm very sorry. I was just trying to unmute it, but I couldn't. I'm really sorry.
That's okay. All right, let's try it again.
From the beginning or just after this?
Yeah, from the beginning. Otherwise, this case will not be like anything. Let's do it again.
Yeah.
That's fine.
Okay. Okay. So I don't need time. I can just start.
Yes.
Hi, this is Dr. Faisal, one of the doctor here today, and I'm your doctor here today. Good morning. Can I please know how can I address you?
Uh, it's John.
John, very nice to meet you. I am the doctor here today for you. And today whatever we'll discuss with you, that will be among you and me, unless it can cause any harm to you or others. Is that all right?
Yeah.
John, can you please tell me what brought you here today?
Oh, it's I just don't want to come here. It's just my wife. It's
Okay.
being very hard.
Oh, I'm so sorry to hear that you are facing some hard time. But I'm here to, and all of us are here to help you. Can you just tell me how is your mood nowadays, Mr. John?
It's not possible. I can't live like this anymore.
Okay, here I can see that one of your patient has died, and after that you tried for the hang. Is this the problem with you, and you came here for that reason?
I could save that patient. It just happened during my care.
No, things are not like that. Don't worry. I'm really sorry to hear that. But can you please tell me, do you feel any low mood nowadays or any high mood?
It is, I just don't feel anything anymore. It's so tough.
Uh,
Just
for how
want to
many days
end
you are
this.
having this problem?
It's been for 3-4 weeks.
I see. So do you feel, sorry for asking this question, it's a routine question I need to ask you.
No, I don't have any of those. It's just like the nurses are talking about me. I could hear them,
Okay, so
and
for
they're
how
just
many
saying that
nurses?
I am the murderer.
Oh,
I am the
sorry.
murderer. They just talk about all about me all the time, and
Oh, don't be
I
so
stopped
sad.
going to the hospital.
I'm so sorry to hear that. So how many people talk with you when you hear anything?
I can't I can't see them, but I can hear them.
Okay. Do you think that somebody is trying to input any thought in your mind?
No,
Do you think anybody is trying to broadcast or withdraw the thought from your mind?
no,
Do you believe you need any medical help?
no. The person who needed the help, he did not get it, and I just killed him. I just want to end my life. It
Uh,
doesn't have any
I'm
more meaning.
I'm really feeling so sorry for your sufferings. And can you please tell me where exactly you are now and what time is it?
It's in the hospital. I don't know the
Do you,
time.
do you know who am I?
Is you the doctor?
So suppose there is a fire in this room, what will you do?
I just want to stay here.
Okay. So do you, I can see that you have attempted for hanging. Is it the first time you have attempted for this or you did this before as well?
This is the first.
I see. And do you have any thought of harming yourself or others?
I already harmed someone, and now I just want to end it. I want to end this suffering.
I'm so sorry.
This life is totally meaningless.
I'm so sorry to hear that. And well, no worries. We all are here. And thank you very much for your cooperation. Now I would go to my examiner. So, dear examiner, my patient John, uh, who is a by profession who is a nurse, came here with some issue like trying to hanging himself, and I can see that his appearance is normal. His behavior is he doesn't have good eye contact with me, and his speech is very slow and it's monotonous, and I can see he's depressed in mood, and his affect is his mood is congruent with the affect. He doesn't have any he has hallucination of hearing some things from some nurses. So he has auditory hallucination, but he doesn't have any tactile or visual hallucination. He doesn't have any thought disorder, and I can see that he doesn't have a good insight. His cognition is good for the place and person, but he doesn't have any cognition for the time. His judgment is not okay. He has a risk of harming himself and harming others. And he has a rapport with me, but he was confused sometimes to do communication with me. So I need to take a reliable history from the other person, like his family member or relatives. And I think Mr. John has a condition which is called major depression with uh, psychosis, sorry, with schizophrenia. So I would like to admit the patient in the hospital as he has a risk. Uh, Thank you very much.
Time up. Thank you, doctor. All right. Thank you, Dr. Faisal. You did really good. And it was just finished on time. So the timing was perfect. All right. Now, I would ask one question to everyone. What's in this case? Even though, like, many of you already know the case, even I'm sure, Dr. Faisal, you also know the case, but what was missed?
Did Dr. Faisal?
Yes, who was talking? Sorry.
Yes, I was just recalling, did Dr. Faisal talk about thought of harming
Yes.
himself?
Yeah, yeah,
Okay.
Yes.
Okay.
Hi, this is Ria. I just want to ask one question. Is there a relevance where the patient has like suicidal risk or suicidal attempt? We are going to ask about the plans or what he is planning to do with himself or what type of weapons they can use. So just to get history, what they are planning.
Yeah, that's a good one, Dr. Huya. But normally, like if the MSc presentation is the task, we don't need to go in that detail unless
Okay.
there's a task called risk assessment. Many times you will end up seeing that task that discuss about the risk assessment to the patient or to the examiner. At that time, those questions will come handy, like does the patient have any previous attempt? And if it was, then how many times? Now, if the patient having any active plan, and what is the plan? Does the patient have any access to any weapon, and what type of weapon? And also we need to find out, like, did the patient have any previous history of doing any self-harm, not just suicide, even self-harm behavior. And there's also some other things that we asked. We will do one of the case with risk assessment, then we will discuss that. Okay.
Yeah, the other thing I was going to ask that because this patient actually came with a wife, is it like relevant to ask the patient in the start that do you want your wife to be by your side or not?
Great. Yes, we can always do that. The important thing is that in case of this kind of thing, in exam, you will never get two role players in the same setting. So there will be always one person. But saying so, if you say that word that, John, I understand that you were here with your wife, but sometimes it is very hard to talk in front of anyone. And you might want to have a very closed space. And I can also arrange that for you. If you want me to ask your wife to just to stay in the waiting room, and then we can talk to each other and try to help each other. So if you say something like that, that is really good. Not a problem with that.
Okay, thanks.
Doctor, can I ask you one question?
Yes, go on.
If in case of repressed patient, if I see that the patient is very slow and if I see that I will not be able to complete everything in time, in that case, should I skip anything or I should just continue? Because if I don't have time, I cannot present the MSc to the examiner. So in that case, what
Yes.
should I do actually?
In that case, like just stick to the aseptic J3R questionnaire. Don't go anywhere. Like you did not, right? You did not ask about heads. You did not ask about SADMA, and that's the perfect approach because you will not be able to finish this case with asking those questions in here because patient will be more slow than what I was. Okay, so it is a very tough case to finish, even though it looks very easy. But the actors are very good. They don't even talk. Okay, you'll just end up asking them a lot of questions. They will not even talk, whatever you say. So you just need to just make sure that you give some time to the patient. Don't rush with your question, but just maybe 30 seconds will be lost in here initially. But after that, you just ask questions just like you did. Okay.
I have a question.
Yes,
In
Dr.
this
Marlene.
kind of case, do we need to ask about suicidal risk in detail?
Not in detail, unless there is a risk assessment task is there, then we don't need to ask in detail, because your task is not about just risk assessment in here, just MSc presentation is your task.
So
Right.
we can just skip suicidal part. We can just focus on aseptic JRR.
Yes, aseptic J3R will be your main focus, but at least I would say that because this patient is coming to you with a hanging presentation, so
Yeah.
question is important, like, do you have any active thoughts of harming yourself or
Okay,
others?
start with this approach and
Yeah.
then we can just follow aseptic JRR.
Yes. Remember the format that we have done in the last class? So we start with mood, sleep and appetite, suicidal risk. Then we go for the hallucination, a delusion, insight, cognition, judgment. That's the format that we will use here. In that way, everything will be covered. Nothing will be missed. Okay. Now, still none of you was able to say which was missed in here. So a patient who has severe depression with psychosis, what is the important thing that you can find in delusion? I'm giving you the
Delusion of guilt.
Yes, that's right. So delusion of guilt is the most important thing in here, because this patient is obviously having a guilty feeling. So if you have to ask it that, do you think, or you can say that, do you think that, did you strongly believe that you were the reason that the patient died? So if patient strongly believe that, yes, I am the reason, then yes, patient having a delusion of guilt as well. And that is a very common finding in your exam in these cases. So that's why, like I always say, find out in your head that this patient, obviously you know that this patient having a depression. There is no other thing that can happen to this patient. So what is important in a depression patient? Mood, sleep and appetite. What else? Suicidal risk, hallucination. Yes, there is a possibility of hallucination like this patient had. They can hear others saying the murderer. So auditory hallucination is likely a possibility. Then delusion, no other delusion would be there, but delusion of guilt is a possibility. Insight, judgment, cognition sometimes will be impaired, sometimes might be normal, depending on how severe is the depression. So that is important. Now, in this case, how we would present MSE to the examiner, we would follow what Dr. Faisal has done. It was good. So just let's say that I would start in that way. Dear examiner, I am presenting the mental state examination of my patient John, who is a nurse brought by his wife because he was trying to hang himself with a rope since a patient died during his care. In terms of appearance, he looked very gloomy and stressed. He was not maintaining eye contact with me throughout the conversation. There was no distractibility. He was not responding to any internal stimuli. And he dressed appropriate to the weather and well-groomed. Speech was very slow and monotonous, but there was no rapid pressure speech or disorganized speech. In terms of emotion, mood was low, and the affect I have observed that is also congruent with the mood. In regards to perception, my patient was having auditory hallucination because he was able to hear some nurses talking about him. But there was no visual or tactile hallucination. Thought form was linear. There was no loosening of association. There is no flight of ideas. In terms of thought content, my patient was having delusion of guilt because he strongly believed that he was the reason of that patient's death. Insight was lost. Cognition was intact, but not intact to the time. Judgment was poor. My patient is a high-risk patient because of active suicidal ideation, active hallucination, and delusion. I was able to maintain a good rapport with my patient, and the history was not reliable. So I would like to take a collateral history from his wife. You end there. You don't give the diagnosis because that is not your task. And if diagnosis is a task, it will be severe depression with psychosis. We never say severe depression with schizophrenia. Okay, so the diagnosis would be severe depression with psychosis. If they are asking that, your MSE presentation does not need you to give you the diagnosis unless it is asked in your task.
Sorry, Dr. Arshan, I have a question.
Yes, Dr. Bharat.
So this patient said that some people, like the other nurses, are talking behind his back. So how can we differentiate that from like a reality, or if the patient has ideas of reference or auditory hallucinations?
I would like remember the question that asked that I can't see them, I can only hear them.
Oh, yeah.
So so that actually explained your question, because if patient was able to see them, then we would use the term of idea of reference, okay, or delusion of reference mainly.
Sure, thanks.
No worries.
Hello, can I ask one question?
Yes, what's your name, doctor?
My name is Salman.
Salman, yes, right.
Okay. You in the mental state examination, while presenting the examiner, you talked about appearance. But here we cannot see the patient. How we can talk about the appearance of the patient?
Just don't get bothered with that. You will be able to see patients in your exam. I'm just using it as like what you can expect in the exam. That's all, nothing else.
So in online examination, we will see the picture or video.
Yes.
There will be video.
You will be able to see the patient in online exam. So they will come in front of you.
Okay, thank you. Then we will also talk about his behavior, how he's reacting, or he's moving, or maintaining eye-to-eye contact, or cooperative or non-cooperative.
Yes. So whatever you see in the patient online, you will just say about that.
So if we are unable to see the patient, then we can say that we are unable to see the patient. So we cannot talk about the appearance of the patient. Is it so?
You will be able to see the patient in exam. There will be no way, okay, because that is an exam. You will be able to see the patient. But in here, when you are doing role play, if you just say that you can't assess the appearance because you can't see the patient, that's fine.
Okay, thank you.
No worries. All good. So that's one of the other psychiatric role play. I hope that you guys are understanding it gradually, how to do these cases, right? Now we will do a MSE video case, which is really important for the exam. It looks very easy, but you will see how people can get messed up. Okay. So who wants to do a MSE video case? Dr. Shamrat. I would not ask you to do it. There is a reason. You already did the course, right? You will do a role play with me, Dr. Samrat, okay? Dr. Afsana, yes, let's try.
Hello?
Yes. All right, how are you?
Yes, doctor, I'm doing fine. How are you?
I'm good. Okay, so I'll give you a MSc video, and the MSc video, you haven't, like, I don't know that if you have done it before, but the video thing is that you get a 4 to 5 minutes in your exam. Okay. And this usually happens in face-to-face. I haven't seen much in online, but in face-to-face, this is a very important one. So they show you a video on a screen, and then you just write your finding and present the MSc after the video is stopped. Okay?
Okay. Okay.
So let's start with that. So this is your case. And obviously, just give it a read and let me know when you are ready. I will start the video.
Okay. Okay, sir, I'm ready.
Okay, so your video is starting.
Okay.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with and your GP who's asked me to see you.
Okay.
I hear there've been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours,
Mm-hmm.
police, people spying on me in my street. None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well.
So when did things start?
Sir,
Sorry.
the video stopped.
Yeah, sorry. Can you hear it properly?
Yes.
Yes, okay, continue then.
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. And that at first they thought I couldn't hear it, but now they know that I know that they're there. Saying things about me through the window. Talking about what I'm doing. I know they're doing it. Whenever I leave my front door, woman at number 7, she's always there. She's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They're just. I think they want me out.
Mm-hmm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline?
Yep. Somebody rings me or I ring somebody. Between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. What else? Well, it could be, but every single time, and then they're talking to me, and then they know what I've been saying down the phone.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Always on the phone again. Always reading that book again. I can hear them saying it, and they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's. Something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, and making a commentary on your actions.
Every day.
Every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think I'm off my rocker, but they don't see it. They're not living with it every day.
Okay. So your friends are worried as well?
Yeah.
So
well, worried or, I mean, I don't think they're on it. I don't think, but they know a lot about what's been going on. I don't know, maybe the police have been talking to them or something, or maybe my neighbours have been talking to them.
Okay.
I don't know. Again, you'd have to ask them. But, it's hard to know. It's hard to know who to talk to because they all,
So
They're all involved.
So this started happening a few months ago. Has it had any other effects on your life?
Well, yeah.
Such as?
Can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. I'm trying to stay out of people's way. I've hardly slept. I've hardly slept for the last, I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until. I don't tend to go to sleep until after 2, 3. When I'm sure that they've turned everything off.
Right. Okay.
Downstairs, and just can't. I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. All they need is one of them, and they can just. But yeah, TV. They've got the local news. If ever I watch that, there's always some little comment. There's always something they say in there at the end about what's been going on. Pretty much every time I turn the TV on now.
Okay.
I mean, it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean the cable?
The cable TV. It runs down the street. Everybody's got access to it if they know what they're doing.
So obviously, this is all very distressing. All the different things that are happening. Can I take you back a little bit and just find out a bit more about you? I think your doctor said you're age 29.
Yeah, 20.
All right. So now you have got 2-minute time to present your AMSE. Your time is started.
Okay. Dear examiner, I want to present the mental status examination of my patient. On appearance and behavior, the patient seems well dressed and well groomed. He was maintaining eye contact with the doctor, but the patient seems stressed, and he was restless. In terms of his speech was pressured and it was rapid. Then in terms of emotion, the emotion was not assessed uh, during the conversation. Then in terms of perception, the patient was having auditory hallucination, as he mentioned that he was hearing voices in the telephone. Then in terms of thought content, it was a linear. In terms of thought form, it was linear. In terms of thought content, the patient was having delusion of persecution, as he was saying that police and neighbor, everyone was spying on him. Then he was having delusion of reference as well, and thought broadcasting. The insight, cognition and judgment was not assessed, and the doctor was able to maintain a good rapport with the patient, uh, but I think his history was not that much reliable, so it would be a good idea if we can take a collateral history, and in terms of risk assessment, he is high risk because he is having active hallucination and delusion. Thank you.
All right, great, did good. So that was really nice.
Thank you.
So, Dr. Afsana, so you did really nice presentation. So always try to add one other thing. Oh, your time just stopped now. Okay, so always try to add one thing initially, like you already know that what was the presentation of this patient. So, so say that, dear examiner, I would like to present mental state examination of a patient who presented with a recent change in behavior with a history of schizophrenic illness. So that gives an idea or like the introduction of the case. I always ask everyone to do that because it's a very good way to start this kind of thing. Apart from that, you did everything good. Appearance, in terms of appearance, patient was well dressed, well groomed, and he was sitting in a stooped posture throughout the discussion. He was maintaining eye contact, but he was obviously restless. and he was not responding to any internal stimuli throughout the session. Then speech was pressured, I would say. It was not like a normal, but speech was pressured, but not rapid. It's not a rapid speech. You would see what is a rapid speech, but it is a pressured speech, you can say. And then you can say there was no disorganized speech, there was no slow monotonous speech that you can always add here. Emotion was not assessed. That was very good that you did not say that emotion was low or something like that. A lot of candidate does that. So if something is not done in the video, always say it is not assessed. And perception, auditory hallucination was there. Thought form was linear because you were understanding the patient. Thought content, in terms of thought content, there was a lot of finding. So you talked about delusion of persecution because police and neighbors spying on him. Delusion of reference is important here because everyone is commenting on him. Yeah.
Yes.
So delusion of reference, you said. And then also you told about thought broadcasting because the TV newspaper knows about everything that he's doing. Other thing also you can add like thought withdrawal, because patient one time he said that they know what I am thinking. So if they know what I'm thinking, obviously my thought is getting withdrawn. So if you have to give logic when you say something in the exam, let's say when you say delusion of persecution, you say that police and neighbors were spying on him. So that's a logic or reasoning. If I say thought withdrawal, I would say patient told that they know what I am thinking. If I say thought broadcasting, then I would say patient told that TV newspapers were discussing about him. There was something always about him on the TV newspaper. So this is a very good idea in the exam to give a reason that why you think so. Because you have a lot of time in here to present the MSE, so use that time. And
I
yes,
thought I would be running out of time. That's why I did.
Yeah. No, you did good. It's such, I'm just saying that like what you can add, but you did good. You are passing this station without any thought. Okay.
Thank you.
So 3R, risk, rapport, reliability. Yeah, you did right. Patient is a high risk or moderate to high risk patient. Rapport was well built and it is not reliable, obviously. So it's a good idea to take a collateral history. Now, other thing is, I don't know who said that, but Oppo R17, yes, that he said he's worried. Is that commentable in mood? I would not add it because the doctor did not ask specifically how is your mood. If you say that mood was not assessed in the video, but affect that I have observed, it seems patient was stressed about it. If you say that, there is nothing wrong about it because as affect is something what you think patient is having. So you can always comment on affect, but the mood would be, it depends on what patient says that, yes, I feel low, I feel high, okay, I feel worried. So if patient says something like that, you can always say in the mood one. Yeah, patient seems fidgety, anxious, restless. You can always say that in the appearance in here.
Sir, I wanted to ask a question regarding the first one. When that was the uni student and had a history of schizophrenia from disease, and now the task was give a differential diagnosis and also the diagnosis. So how I can say that this is a relapse of his previous disease or the new onset of schizophrenia? Like according to the duration, I would say, or
it is very hard to say because if a patient had a history of schizophrenia from disorder, that it's a good way. Like I would always say it's a relapse rather than saying a new onset, because patient was given the medication, he did not continue it, so that's a relapse of schizophrenia. That's your diagnosis. If you get a previous history of schizophrenia or schizophreniform, and now patient presenting with a psychosis, the diagnosis is relapse. all right, because it has already been diagnosed for the patient. But the new onset means that this patient never had schizophrenia before, and now for the first time you are diagnosing the patient with a schizophrenia.
Okay. Okay, sir. Thank you.
No worries. You did good, Dr. Afsana.
Thank you.
All right. So that is how the video of this MSE cases comes in exam. All right. And it is easier than history, obviously, right? But sometimes if you miss a small thing in here, they will fail you because they think that it has to be perfect. And by responding to internal stimuli, you will find out in the exam sometimes that patient with psychosis, they tend to respond to some unseen or internal stimuli, which means they might be looking at the ceiling as if they are seeing someone there. All right, or they might be talking to someone, but you can't see them. That means they're responding to internal or unseen stimuli. Like the first case, when I said that, President, I'm coming. That is, I am responding to some unseen stimuli. All right, so who wants to do the next one? No, insight was not assessed, Dr. Ney. Yeah, Dr. Shamrad, and then Dr. Pratt. Okay. Dr. Shamrad, you can unmute yourself, or I have to do it for you. Okay.
Hello, doctor.
All right, Dr. Shamrad, how are you?
I'm good, doctor. How are you?
I'm good. All right, so let me give you a case. How many minutes for presenting MSE after a video? Now, this depends on the exam. Many times I have seen that it's 4-minute video, 4-minute MSE presentation. Many times 6-minute video, 2-minute MSE presentation. All right, so let's do this one. Dr. Samrat, so this is your case. Your 1-minute time started.
Okay.
Also, Dr. Shamrat, do a risk assessment in this case.
Okay, doctor. Do I get any time form, doctor?
No, same time. All right, so this is your case. Your patient name is David. You can start.
Hello, my name is Samrat. I'm one of the doctor here. How can I address you?
Is David?
Nice to meet you, David. So I can see that you have been brought by the police. Can you please tell me what's going on, David?
Just stop talking about me. Just, will you stop it? No, it's not about you always. It's why you are talking about me. No, you need to stop about it. No, I'm not cheating you anymore. No, what? No, I did not date with your ex-boyfriend. What are you saying? Stop saying that. Stop being paranoid like this. It's just not what you think. No. Stop it.
David, can you please tell me like what's going on? Are you having any pain at the moment? I can see some ulcer as well on your legs. So do you have any pain?
What are you talking about? I don't have anything. I'm fine.
Okay. Yes. David, I would like to ask you a few more questions to find out what's going on with you, and it will be confidential between you and me until and unless it's harmful to you and others. So can you please tell me like what exactly is going on? You said that
about me all the time. I don't know like what's happening. I haven't done anything wrong, and the whole neighborhood is talking about me. I just don't understand. I'm not doing anything wrong. Yes, I understand that he was my friend and he was his boyfriend at that time, but that's fine. I'm not doing anything wrong at the moment. They are just accusing me something like I'm cheating with my friend. I don't understand.
So may I know who is accusing you?
It's one of my friend, and he's also my friend.
Oh,
Not he was friend.
okay. So can you see him as well?
Yes, obviously I can see him, but I can hear him saying bad things about me all the time. And he's also saying things to the other neighbors, and the neighbors are also talking about it. I can understand that whenever I go outside in the street, everyone is looking at me. They're not saying anything at that time, but I know that they are saying something. I can feel it.
Okay. So since when it's going on, David?
It's been 2 months this is happening. And they have to stop it. Now this is in an extreme thing that I can't tolerate anymore. And they just want me to leave this place, I know.
Yeah, I can see that it must be really hard for you, David. Okay, but please don't worry. I will try to do my best. And can you please tell me, like, by any chances, like, do you think that, you are hearing some voices as well? And
yes, I can hear them. All the neighbors are talking about me. They think that I cheat with my friends, I do bad things, and I don't have any God. They're just saying all awful things about me.
And by any chance, do you feel them as well in your body?
No, who feels people?
Okay, yes. And how about like, how is your mood nowadays, David?
It's just like I can't handle it anymore, doctor. Like it's just becoming so upsetting for me. I just want to finish everything. This is my beyond my limit. I can't tolerate it anymore.
Okay. And
I'm
how
very
about like,
stressed.
do you think life is worth living?
Yes, I feel that.
Okay. By any chances you are trying to harm to others? Have you felt
Yeah,
like that?
Sometimes I just want to kill that stupid man.
Okay. And do you think you need a medical help at the moment?
No, why I would need medical help?
And do you know where you are at the moment?
Yes, that stupid police brought me to the hospital. I don't have any problem. The problem is with the neighbors. The problem is with my friend who is trying to accuse me of something which I haven't done.
Okay, just a silly question. If there is a fire in the room, what will you do, David?
There's fire? Where is the fire?
No, and just a routine question. If there's not a fire, David. Yeah.
I will.
What will you do? Okay, you will flee. Okay, yeah. Thanks. And by any chance, like, do you smoke, drink alcohol, and recreational drugs?
Sometimes, yes, I just use some marijuana, that's all.
Okay. And how about like, have you been diagnosed with any other medical conditions so far?
No.
No. Okay. And okay. Well, thank you for the information, David. Now I would like to go to examiner and I will come back to you. Will that be fine?
Yep.
Yeah. Well, thank you. Dear examiner, I would like to present the mental status examination of 47 years old man who has been brought by police, and he also has some venous ulcer over a medial malleolus. So on appearance, well, I can't comment on appearance because I can't see him. And in terms of behavior, he was cooperative, and I can see that he was sometimes restless as well in the meantime. And I couldn't comment on whether he was responding to unseen stimuli or not. In emotion, he said that his mood was not. He said that his mood is fine, and in perception, he's having auditory hallucination. As he said that he can hear the voices. I could not appreciate any visual or tactile hallucination. In thought form, the thought form was he was answering the question appropriately. So I would say thought form was linear, and there was no any tangentiality or any circumstantiality. But sometimes I can feel that there was some concrete thinking as well. In thought content, I can find there was delusion of reference and delusion of persecution as well. And insight was lost. Cognition and judgment was present. In terms of risks, I can see he's having some auditory hallucination, and he thinks that people are talking about him, and he's living in the street, and he's using some marijuana as well. So I think that he's in a high risk. In terms of rapport, I think that the rapport was not good. And in terms of reliability, I would like to take the collateral history from the police because he's having auditory hallucinations. So it's not reliable. And yeah, that's it. Thank you, Doctor.
Right, you have got 3 seconds left. And that's finished. All right, thank you, Dr. Shamrat. You did good.
Thank you, Doctor.
Now, I think like the way that you did, it was all right. You would not fail the case, but I would rather say some of the other important things should be done in here. Couple of things, let's say, in your relevant assessment, it is not just a MSE questionnaire because risk assessment is a task, which means that the heads will be an important questions in here. Like you have to ask the heads. So you need to find out the home situation. How is the financial situation? Does he have got any kind of support or not? Because that is included in your risk assessment. Okay. So let's say that obviously you started. Now, I have noticed one thing, that none of you are giving the confidentiality statement in a nice way that I wanted you guys to do. Like always try to say something nice, because maybe you will get approach 5 or 6 in the exam. And even if you get 3 in somewhere else, as an average, you will end up getting a 4, which means a pass test score. So this approach is what makes our candidate passing the exam most of the time, because they have a very good approach to deal with these cases. So sometimes even if somehow they miss a little bit, the average becomes fine. Globally, they pass. So what is important is that you say something nice. Obviously, like, hi, J. David, this is Dr. Shamrat. I'm one of the doctor here. I understand that police has brought you from the street, and I can see that you are having some ulcer on your leg. I'm very sorry to hear all of it. Now, I need you to ask you a few questions because the police has brought you here, and I have to make sure that you are healthy enough to go back to your home. But I want you to know that whatever we are discussing here, it is confidential. Unless it is very harmful for you or others, I will not say anything that you say to me, even to the police. But I need you to understand that I'm here to help you in every possible way. There is nothing that might sound silly to me. There is nothing that make me feel just or embarrassed about you. So please be frank with me. This is a very open space for you. So would you please tell me a little bit more that what exactly happened with the police and why he has brought you here? So you can always ask an open-ended question, that's fine. And then you start your MSE question. So how is your mood these days? Any times do you feel really high or low? Okay, then how's your sleep and appetite? Do you feel life is worth living? Then you can ask about, do you see, feel, or hear things that others don't? Now, obviously, these things will not always work out because many times patients just start talking and you understand that they might be talking to someone, they might be hearing someone. So you can always start asking the hallucination question first and then go back to the mood, sleep, appetite question. So that is always all right. There is no problem with that. So then obviously you need to find out a detail about these things, like how long this is happening, that Dr. Shamrat has asked. That was very good. And then you need to find out that, can you tell me a little bit more about what actually happening with you? And then they will give you every information that, as I said, you need to find out that specifically you want to find out that, are you able to see anyone? Are you able to see anyone when others don't? Okay. Are you able to hear them saying anything? So you need to ask these things so that you can actually say, yes, this patient has got hallucination, this patient has got delusion, and what kind of delusion it is. Do you think that they are trying to harm you or spy on you? You can always ask this question proactively to make sure that you are not missing something. Specifically, I felt like Dr. Shamrat has not asked any question about thought insertion, thought withdrawal, or thought broadcasting. If he would ask, I would give him some positive findings in that part. So that was important, that was missed. And apart from that, then you go to the heads. Heads is very important in a risk assessment questionnaire. So you need to find out that, who do you live with? Where do you live? Do you have enough support? Do you have any financial issues? Do you do any work? You will find out that this patient is at the moment in the street. He doesn't have anyone. And he's mainly talking about the street neighbors. That means there are some other people who is also living in this street and he's talking about them. Okay. And so that's important because this patient has got an ulcer. He doesn't care about it. Right? That means this patient is a high risk already because he's lacking medical insight to seek some help about that. So that's important. HC is always important in risk assessment. Then ask about SADMA. You can very quickly ask about a past history and family history. In the risk assessment, I would say that this patient is moderate to severe risk based on that he is having active hallucination and active delusion. He's living on the street. He is also abusing marijuana. He does not have insight judgment. And also you can say that especially he does not have any social support. So these are the main thing that we look for in a risk assessment. Remember that we wanted to talk about this. So let me just show you that what is actually risk assessment. We have something here, yes. So that's called SAT persons scaling. In SAT person scaling, we use this form to find out how severe a person can have. So S for sex, which is the male sex, get 1 point. Age less than 20, more than 44 get 1 point. Then D for depression, P for previous suicidal attempt, E for excess alcohol or substance use, rational thinking loss, social support lacking, organized plan, no spouse, and sickness. Okay, so if you look at here, our patient is male, 1 point, age 47, 2 point, substance abuse, 3 point, rational thinking loss, 4 point, social support lack, 5 point, no spouse, 6 point, his sickness, this patient is sick, 1, 2, 3, 4, 5, 6, 7. 6 or 7, you can say. Sickness may or may not be, at least 6. So it still falls under medium to high risk. So that's how we say that this patient is a medium risk or high risk. So it's a good idea. If you don't get suicidal ideation previous attempt, then keep it under a medium to high risk criteria that will cover you for both. Yes, so because I added the risk assessment, when risk assessment is added in the task, then yes, you have to ask the complete history. Because then the question is also different. They don't ask you to just do MSE, they say do relevant assessment. So you see the task, that is important because the next task is risk assessment. First task is relevant assessment. Otherwise, they would just say, do or like assess the patient for mental status examination, something like that. Now, about the venous ulcer, Dr. Afsana, only one thing is fine, that I'm very sorry to know that you are having an ulcer on your leg. Please don't worry, I will take care of it. Okay, so just one thing is fine. You don't need to go in detail about it. But one other thing, like you can always say that I can see from the note that you are having a break in your skin on your leg. Is it painful? Is it bothering you? Patient will say, no, nothing, doctor. All right, I understand. I can see that there is some break. I will just trace it for you and I will take care of it. So say something, just at least 1 or 2 sentences about that. That will cover you for this ulcer. Okay, I will unmute. You guys can unmute and then ask questions about this one. That's fine. So what were the positive findings? The positive findings in this case, obviously, your appearance, you can't say anything. Speech was normal, you can say. Emotion, and I did not say that my mood is fine, okay? I said that I am stressed at the end. So that you can say that according to the patient mood was stressed. And the affect was also congruent with the mood. So that was the only thing that was missing, I guess. Then perception, this patient obviously had a auditory hallucination. Then thought form was linear. Thought content, what was in the thought content in this case? So delusion of persecution, yes, because he's thinking that the neighbors are accusing him of something. That's fine. Delusion of reference. Then other thing that you could, if Dr. Shamrat was asking about, like, do you think TV newspaper talking about you? Do you think that the neighbors are taking thoughts from your mind? Then I would say yes. I think like whatever I am thinking, neighbors already know about it. So that was another positive finding in this case, which was missed. All right. And apart from that, insight was lost, cognition was not normal, and then judgment was also not intact. Now, there is one thing that Dr. Shamrat has said, which was very good, concrete thinking. What is concrete thinking? Concrete thinking means that the way that I reacted when I found out that there is a fire in the room. I say that, where is the fire? Where is the fire? But Dr. Sharma had already told me that, well, this is just an assumption that you will do if there is a fire in the room. But still, I just reacted in that way. That is a concrete thinking, okay? Because they don't understand the question, the way of question. So those kind of concrete thinking can be there in a schizophrenia patient. All right, but I say that I will run away. So judgment was intact in that case, right? Just the insight was lost. Obviously, this patient is a moderate to high risk patient. Rapport was well built and not reliable. So obviously, you need to take a collateral from police. Any question?
Do we get any time from doctor in this sort of scenario in exam?
It depends. If they want to give you, they will write it in the task that history for 3 minutes or MSE for 2 minutes. So they will write it for you. If they don't write it, then you don't get it.
Thank you.
In face-to-face exam, is there any stopwatch coming on screen, or we can put our own?
No, you can't take your like your watch, and there will be no watch in your exam room also. It's all about in your head. You have to maintain time in your head, unfortunately.
No, online. For online, there is also no stopwatch on screen.
No, no.
So we can also not put beside ourselves also.
No.
And doctor, how was the speed of my asking questions? Should I increase the speed or should I decrease, or is it okay, doctor? What do you think?
It is okay. I think like the speed was fine. It was not very high speedy thing. But I think like if you want to just add those questions, you have to be a little faster at that time. But you will manage it because still you have 30 seconds, which I have cut out, right? We're doing just a 7-minute 30 seconds. So in your exam, you will get another 20 seconds at least. So we will cover it.
Sir, if the patient is already telling us that he is having hallucinations or he is hearing voices, so do we need to ask again?
No, if you find something already, like if you find delusion of reference, you will not ask it again. So if you haven't found something from the patient history, then you just ask it.
Okay, thank you, sir.
No worries. And Dr. Ney, so if patient says that where is fire, the same way. So you just say that, I'm sorry, there is no fire in the room. This is just an assumption that if there is a fire in the room, what you're going to do. Yes, this patient, yes, that's right, Dr. Anika. This patient actually had a homicidal ideation also, right? Because he said that sometimes I feel like I want to kill that man. So yes, that's one thing you have to add in here as well. And Dr. Shandesh, if they give time, let's say 3 minutes for your history, yes, they are going to say to you that 3 minutes is up. Okay, so somehow you will know that 3 minutes is done. And in case of face-to-face, there is a bell that will run after 3 minutes. They will not say anything, but you will hear a small bell if there is a prompt in your question. So and that's a good question, Dr. Nair, that if you are confused about something, like are you talking it as a thought withdrawal or thought broadcasting? Broadcasting is always TV, newspaper, those kind of things. So if patient says that my thoughts are getting broadcasted in the TV, newspaper, then we only say broadcasting. If patient says that whatever I am thinking, they already know, that people know about it, that's thought withdrawal. Do we get to
Can
write notes in the exam? Yes, you can write notes in the exam where it is 8 minutes inside the station, but not in the 2 minutes outside. Okay.
Can you please tell the things what we need to ask in thought content? Can you please explain a bit?
Thought content. So thought content is the delusion part. Thought form is the, like we talk about, is it a linear thought form? Is it a loosening of association or not? So thought form is actually, if you're understanding the patient's answer, patient answers, patient's conversation or not. Okay. And content is all the delusion questions that you ask. And delusion of control means patient will say that someone is controlling me. Everything that I am doing, I'm not doing that. Someone is controlling that. Okay. All right. Now we'll just finish with another case. So Dr. Brad, you are ready?
Yes, I'm ready.
Okay. Just give me 30 seconds.
Sure.
Thought echoing, Dr. Ne, it is good question. So thought echoing means that when a patient hear their own thoughts loudly after thinking that. So if you're thinking something in your head, and then you can hear that thought just after thinking that, that's thought echoing. Is this understandable?
Yes, doctor. You mean patient is talking about what they are taking in their mind. Am I right?
Yes. Yes. So let's say patient thinking something, and that's just they're also hearing that just after that. So thought in the mind getting echoed later on.
Okay. Thank you, doctor.
No worries. All right, so Dr. Brad, so that's your question. So you have 1 minute and then we will start the case. Now this is not MSE. This is a little bit different. All right, so the father of Sarah, whose name is James, is here to talk to you. You can start.
Hi, James. I am Brad. I'm one of the doctors in this hospital looking after your daughter. It's very nice to meet you. So before we proceed, I just want to make sure that we have the consent from your daughter so that I can have a chat with you regarding her condition.
Yes, I have the consent, doctor. That's fine.
Okay, sure. So can you tell me how much you already know about her? And I just want to reassure you about a confidentiality. Everything that we talk about here will remain confidential between us unless it is of harm to your daughter or anyone else.
Yeah, so it's just like I have noticed something very unusual with Sarah lately. It's just been few weeks that she's not herself anymore, because I know her because she still lives with us.
Mm-hmm.
And I'm seeing that she's not sleeping at night. She's just going out, doing something which she does not do anytime, excessively spending on something which she even doesn't like.
Mm-hmm.
She never liked piano. Now I have found that she's going into piano classes and now even trying to buy a piano by herself.
Mm-hmm.
And the most unexpectedly, like she's going for gambling all the nights. She doesn't even come to home even at late night. So I just don't know what happened. It's not herself anymore. There is obviously something has changed, doctor.
I understand that this could be very distressing for you. So has something like this ever happened before? Has she had any mental issues before?
No, she was always kind of a very lonely kind of girl. She does not get along with others like too much.
Uh-huh.
But she was never like this. Now she is totally the opposite of it.
Sure. And how long has this been going on?
This just for 2 weeks, I guess.
2 weeks. Okay. And have you noticed like any strange behaviors besides, the things that you mentioned? For example, her talking to someone that's not there, or reacting in a bizarre way to like unknown stimuli?
No, I haven't found that.
Mm-hmm. And do you think that she may be using recreational drugs?
Yeah, there is a chance. I'm not sure, but obviously she's all out at nighttime. I don't know what she's doing.
Sure, sure. And how is the home situation, by the way?
Yeah, we are a happy family. Me, my wife, and Sarah. That's our little family.
Okay, sure. And she's studying at the moment. Is she in university?
Yes.
Okay. And how's her grades? How's her performance there?
Her grades were fine, but for a few weeks and like for the last semester, it was good. But this semester, she's just not doing good. Her grades are just horrible. So that's why, like, I'm thinking something has obviously changed in her.
Sure, sure. And have you noticed her having a trauma to her head?
No.
Or having fever, flu-like symptoms?
No.
No. Okay. And have you noticed her having some, obviously, can you tell me about her mood? Like, was it high or low?
It's very high at the moment.
Very high.
He seems very unusually happy.
Okay. And have you noticed her having low moods as well? Anytime?
Not now, but yes, there was times where she was very, very low, crying, and like she was not going to the universities. So there was some times like that.
Sure, sure. All right. And have you noticed her like talking about life not worth living, things like that, ever? Or trying to harm herself?
That time, yes. During that time, she used to harm herself. And even we needed to just take her to the hospital because she wanted to cut her wrist.
Oh, okay. Sure. When was that?
About 2 years ago.
2 years ago. And she didn't have these symptoms that she's having right now then, did she?
No.
No. And has she ever been seen by a psychologist or psychiatrist?
we tried, she has started seeing one psychologist, but just after 2 sessions, she has stopped it.
Sure. And has she been ever on any medications?
No.
Any family history of any mental illnesses?
No.
Nothing. All right. Thank you, James. So I have no further questions. So I think what's going on with your daughter is something that we call bipolar affective disorder. And this episode that she has, we call it mania. Have you ever heard of it?
No, doctor. What's that?
So bipolar disorder is basically kind of a mood disorder in which the patient has 2 complete different sides. Sometimes they are very hyperactive, very happy, and they overexpand, they have lots of energy and go around doing many things. And sometimes they have a very low mood and they cry and they want to kill themselves, they want to commit suicide, and these kind of things. All right. So that's why we call it bipolar affective disorder. Are you following me so far?
Yes, doctor.
Okay, please don't hesitate to stop me if you come up with any questions and I'll explain further. So it is actually not an uncommon condition, and it happens because of a certain imbalance in some chemicals in the brain. Usually it has a genetic background. Sometimes some family members have the same issue. Also, it could be due to using some drugs, such as ice, marijuana. These also can cause these kind of issues as well. Sometimes a trauma to the head can cause it, or some hormonal imbalance also. So in your daughter, we have to dig a little bit deeper and take a full history from her to find out what the cause is. Could be due to drugs that you said it's possible. And what we do usually in these cases is, of course, because she was very hyper, she needed to be admitted. So we will take care of her here.
Continue, Dr. Brad. That's fine.
Okay, so we will take care of her here. We will. She will be seen by a psychiatrist and psychologist on a regular basis. We will give her medications, and she will remain with us until her mood becomes stable. And then when we feel that she's safe to go back home, she will be discharged, and she will be followed up in the community by her GP, psychologist, and psychiatrist on a regular basis. Do you have any questions?
No, doctor. Does she need any medication now?
I believe we have started medications when she arrived here in our emergency department. Yes.
Okay. All right. All good, Dr. Brad. Thank you. Thank you for this. You did really good. I'm happy how you do the cages. Your approach is really nice.
Thanks.
Okay. Now, so this case is a little unusual, right? It's not like a usual cases where you just take history from the patient, give diagnosis. It's a little different from other. Now, just past and family history for 3 minutes. And that means you just need to take a little bit of history about the past history, especially the depression history that she had, because that's how you diagnose the bipolar. So the important thing that Dr. Brad has done, which I was happy about, is about the confidentiality, because it is an 18-year-old and we are talking to the father. We have to make sure that the father has the consent to discuss about the daughter condition. That's the most important thing in this case. Once you have got that positive sign from the father, that's fine. You don't need to go to the examiner and ask examiner that, examiner, I want to confirm if the father has consent. You don't need to do that. If father says he has consent, we believe that. After that, we start asking the questions. We give enough confidentiality. We follow our own approach as we do. And then obviously you ask about, like, can you tell me what's happening? Then again, he will say everything that's happening. You already know that this patient is manic. You need to find out the duration of the symptom, because that's how you know that it is a hypomania or manic episode. That's important. After that, you can ask some of the questions which was missing from mania, especially how is her mood these days? Anytime does she have low mood or does she cry a lot? That's the time you will end up finding that yes, there was some time where she was very sad, gloomy, crying, had all the depression feature. So just to confirm that it was depression, you can ask some depression questions at that time, like, can you tell me like how was her mood these days? How was her sleeping? Did she lose weight during that time? How was her energy? Was she having lacking of motivation? Did she have any suicidal thoughts or any self-harming behavior? So all the MSE questions of depression you can ask in the past history. And obviously, like, did she take any psychological or psychiatrist appointment? Did she had any medication? Ask about the family history, which means the heads, and also the SADMA, which Dr. Brad has asked. So that's how you finish it. Very important is SADMA, especially drug-induced one. Explain diagnosis with reason. This is bipolar affective disorder. Now, when someone has got one full-blown manic episode with a depressive episode, that is bipolar 1. If it is a hypomania, which means the duration of this hyper elevation or hyper alertness is less than a week, that's hypomania. So if it is only hypomania plus depression, that's bipolar 2. So our patient actually had a bipolar 1 because the symptoms are persisting for more than a week. And obviously it is affecting her university life, her social life. So that is a manic episode. So bipolar 1, even if you just say bipolar affective disorder, that's fine. There is no need to be that perfect like bipolar 1 or bipolar 2. But if you do it, that's also good. So the reason, obviously bipolar affective disorder, we always use our own term in these cases because there is no specific definition of it. So if anyone say that, well, let me draw a picture for your better understanding. So let's have a look at this line. A normal healthy individual's mood usually stays along this baseline, sometimes just a little bit of variation in each and every day. But in bipolar disorder patient, sometimes their mood becomes very high. They tend to get excessive energy, decreased need of any sleeping, and also they indulge themselves with excessive spending, gambling, and involving themselves with a lot of goal-directed activities. And that becomes severe enough that they affect their social life, family life, occupational life. And at certain stages, they also have just the opposite of this hyper-elation, where they feel very low, crying episodes, they feel less motivated, lack of energy, even sometimes self-harming behavior. So these mood swings that you have seen in your Sarah, that is exactly what we call it as a bipolar affective disorder. And then you'll say that it is not uncommon, it has sometimes genetic, hormonal, drug-induced, all of these things Dr. Brad has said, that's perfect. Management. The management part is important in here because you have to say short-term and long-term management. In case of short-term management, obviously Sarah needs to be admitted to the hospital, even it's under Involuntary Mental Health Act, because at the moment she's not having enough insight of her problem, and she is risky to herself as well as to others. So that is the reason she needs to be admitted in the hospital until she becomes stable. You will also involve the acute mental health team in the hospital, which comprises of psychiatrist, psychologist, and a mental health nurse. The psychiatrist will come and review her and most likely will start her on acute mania medication, which is the most likely it's like an antipsychotic medication like olanzapine or risperidone. Once she becomes stable, then obviously she might get good chance of relief by seeing a psychologist who can discuss about what's happening with her and how to deal with that. And then obviously when she is discharged, she will also have help from the community nurse who can look after her, who can make any further referral needed. You will also make a referral to her usual GP so that GP can review her regularly. Don't forget to do some organic investigation in here, just some basic blood, including a drug screening for blood and urine. That is must. Okay, so that's how you manage this kind of cases, short-term, long-term, and a organic workup. All good? Any question?
Dr. Ashen, what should I have changed in my approach? Because I had some issues with the time management.
I would say that you were taking a lot of break in between. It's actually your style of talking. Like this is how you are doing it. But in terms of the exam purpose, I would say be a little fast in between each of the questions that you're asking, rather than giving multiple long break. I felt like I would love to hear something like you if I went to a doctor in a general practice or anywhere else. That gap is really good in terms of like a patient-doctor conversation. But for exam purpose, because you are running out of time, I would be a little fast. I would not be like giving a lot of break in between asking a questions. Okay?
Sure. Thanks.
All right. Yes, Dr. Alina, the CAT team is mainly the team that the GP usually involve. If you're in a GP setting, then you involve the CAT team, and CAT team actually talks to the patient over the phone to assess how severe the patient is and if they want to see the patient in hospital. So in a GP setting, you involve the CAT team. And if it's in a hospital setting, then you involve the acute care team or acute mental health team. But both of them are pretty much same. Okay, so it's not too different. So CAT means crisis assessment team. Okay, so usually in a GP setting, if a patient is very aggressive and violent, that is a crisis for you. So that time you call the crisis assessment team. They assess the patient and then they give you information what you should do next.
When you discuss further management, so what should we supposed to tell? Like we should tell about medication, or like we should name the medication, or just superficial thing, like we have to admit the patient.
Superficial is fine.
Okay.
Superficial is fine. That means admit the patient under involuntary act if patient does not agree and why it is important. Then after admission, what you do, you involve your acute mental health team and who are they and what they are going to do. They are going to start her on medication. What medication? Especially an antipsychotic medication. If you don't want to say the name, that's not a problem. Just at least antipsychotic medication if you say, or mood stabilizers, that's fine.
Okay, so we don't have to name the drug, only the base. Okay.
No, yeah. Even if you say the name like olanzapine, risperidone, if you say it, that's not a problem for exam. But you don't need to give the dose. You don't need to like not too much deep.
And is this for the psychiatry portion or just for the medicine? For every
everything. For everything, if you are talking to a patient, you don't need to go in that detail. Just superficial. What you are going to give, antibiotic, painkiller, like that.
Okay, thank you.
No worries. So that's all good. Now I feel like there is one thing that I haven't done today. There is another case which I would like to do, because that's without that case, finishing a psychiatry MSE role play should not be like that. So let's do another role play and then finish this. Who wants to do the role play? There is a code, especially in a GP setting. If you think that someone is attacking you, there is a code that you can press, and then someone will help you. Someone will help you. Same in hospital. Okay, so Dr. Hiva, I'm unmuting you.
Yeah, I'm on mute. Hi, doctor.
All right. Hi, how are you?
Good, good.
Good. All right, so let's do this case. Just a second, okay? All right, doctor. This is your case. Your 1 minute time just started.
Okay, sure.
All right, so this is your patient. Your patient name is Jenny. You can start.
Hi, Jenny. My name is Hiva. I'm one of the doctor here. I appreciate your presence here. How are you today?
I'm so good, doctor. It's like I've never been so good in my life. It's just like you don't know, like this feeling. It's like everything is nice. The color is beautiful. The sky is more blue now. So I just know, like it's just I've been feeling so good for the last few weeks. There is obviously something going on, and I feel like I'm going to invent something very cool. And even that Elon Musk can beat me. I'm going to invent something like a spaceship which can even bring people to the Jupiter, you know? Like I know that professor, they are just worried about it because they can't beat me. And the students, they are not in my level anymore. So they're just jealous about me. So that's I think why they are worried about it. So please don't bother about that counselor. He is just jealous about that. So I can just go home and you don't need to waste any time on me.
Yeah, that's great to hear from you. But I'm really concerned, and we are really concerned as I received a letter from your school counselor that they are a little bit concerned because of little bit downgrading of your performance in the uni. So
Oh, I don't have some time, doctor. I know that those are very like childish thing that they ask for some assignment and those things. I don't have time for that because I'm inventing something much more important than that. Because
yeah,
this invention is going to bring life. This is how we are going to save this planet. And yes, I'm going to win a Nobel Prize for this. So
yeah.
who cares about this school grade?
That's great. I'm really happy to hear about these things, but I'm really concerned about you a little bit, and I don't want to waste your time. I know your time is gold, but I need to ask you a few questions, and this question will be confidential between me and you, just to unless it is harming you or anybody else. Is that fine with you?
Yeah, sure.
Okay, that's great. So I can completely understand that your mood is good, as you said.
Yeah, I'm feeling
Yeah.
so good, doctor. It's just like
That-
everything's good.
That's okay. Do you have any time that your mood is down?
No,
Okay. And since how long you are feeling that great and in this high mood?
few weeks.
Few weeks. And what about your sleep? Are you able to sleep?
I don't need to sleep at all. That's the beauty of it because I don't need any sleeping. I feel energetic. I feel
Okay.
like well, everything is very good around me. I just keep on working on these things. I also involved myself with a lot of other activities at the moment. I'm also going
Okay.
out, meeting a lot of friends now. So life is so colorful now.
That's good. That's good. And what about, I completely understand that the life is colorful, but sometimes when we are passing through a disappointing thing and we are trying to harm ourselves or anybody else, is that happen to you?
Oh, not at all. I don't even care about
Yeah.
anything now because it's
Oh,
about me now.
okay, that's good. By any chance, can you hear or see or feel anything that the other can't?
Do you think I'm crazy, doctor? It's not I'm crazy.
No, I'm sorry for that, but it is just a random question that we are asking our patient about it.
Okay.
Okay, and what about, do you think that anybody is trying to harming you?
No, who can harm me? There is
Yeah,
no one who is going after me, but
yeah.
yes, I know that they are jealous of me.
They are, sorry, I couldn't hear you.
They are very jealous of me.
Yeah, okay. And what about, do you think that you have extra power?
I don't know, but say like I'm obviously special because no one could find
Yeah.
this out for 100 years. So obviously
Okay.
I'm special. I'm meant to do this kind of things.
Okay. By any chance, do you think that anybody trying to insert any thought to your brain or anybody try to withdraw any thought from your brain
No,
or your thought is broadcasted in the TV?
no.
Okay. And do you, I will ask you some random question also, but it is imaginary question. Let's say that there is a fire in this room. What you are going to do?
I would run.
Okay. And do you know where are you now?
Yes, I'm here with the doctor.
What and what is the time now?
I'm not sure. I don't have a watch.
And what is the place?
It's the hospital.
Okay, that's good. And are you smoke or drink?
Sometimes, but now I'm doing a lot. Trust me, for the last 2 weeks, I've tried ice, I have spit, marijuana, every possible thing that you can talk about. So
Oh,
that's why it is so good now.
okay. And with whom you are living?
I'm living with a lot of people at the moment. I'm meeting a lot of new people. I feel like meeting with them and have some like interesting meeting and then just be done with them. So life is so good now.
Okay. Any history or family history of mental health issue?
No?
Okay. And how is your general health?
Yeah, I'm fine.
Okay. And what about any fever, any head trauma?
No?
Okay. And do you have any weather preference?
No?
Okay, that's great. Thanks for your answering and your tolerating me, and thanks for your time. I would like to present the MSE to my examiner. So dear examiner, I'm presenting Jenny. She is one of uni student who was referred to me by a school counselor due to sudden downgrading of her performance, in which I think that she had some manic episode. So her appearance, she look well dressed and groomed, and she's maintaining eye-to-eye contact, and regarding her speech is a high rapid speech in volume and in tone, and there is no slurred speech. Regarding her mood is good, which is congruent with her effect. Regarding the perception, there is no hallucination. As the patient said, there is no hallucination of auditory or visual hallucination or tactile hallucination. Regarding thought, the thought is linear. There is no loss of association. Regarding thought content, there is delusion. There is a grandiosity delusion, there is delusion of jealous, and regarding her perception, we talk about it, there is no hallucination. Regarding her insight, the insight is, sorry?
I'm up, but go on.
Yeah, so regarding her insight, the insight is not impaired, and regarding her judgment, the insight, yeah, and regarding her judgment is okay, and regarding her cognition, she is not oriented to the time, and regarding the risk, she's maintaining a good rapport, and history is reliable, but she's, we need a history from the family. Regarding her risk, she's moderate to high risk because her mood is very high, and the insight is not maintained, and she's taking a lot of drugs. So this is my MSE.
All right, thank you, doctor. You did great. All right, so couple of things that I would add in here. Obviously, the approach is fine. The history is all good. No problem with that. We normally, even if it's a MSc, we try to ask questions in terms of the history that we get. Why it is so? Because if we understand that this patient is having a mania, we try to ask some questions related to mania. So what are those questions actually? Mania patients, obviously their mood will be elevated, like hyper elevated. We will always ask that any times do you get very low or not, to rule out bipolar affective disorder. They have some other feature, sleep. They don't need sleeping because they don't even feel like sleep. So they have this like decreased or reduced need for sleeping. It's not insomnia, okay? They don't feel like sleeping. Then other than that, their energy will be very high, so hyper energetic. So do you feel like you are having excessive energy? Then they indulge themselves with a lot of reckless behavior, reckless activities. So do you think that you're spending a lot of money these days? And if yes, then can you describe it a little bit for me, how you are doing it? So patient tends to do a lot of gambling. Then they also involve themselves with, like, sometimes hypersexuality is also one of the feature of mania. So they meet new people, they end up having having a lot of sexual intercourse with unknown people that increase their risk of having a STI later on. So those are all connected. So gambling, reckless driving, reckless sexual life, all are feature of mania. Okay, so we ask these questions. Then also increased goal-directed activities. So they tend to have a lot of goal-directed activities. They engage themselves in a lot of clubs. They start playing piano, guitar, a lot of things which they have never done before. So increased goal-directed activities, increased energy, reduced need for sleeping, increased mood, Those are main features of mania. So little bit of questions of those things will be a good idea in these cases. Okay, it's not mandatory, but always if you get some time, because you don't need to ask head SADMA in this case because your task is MSE only. So in that case, you will have some time for at least 3-4 questions in terms of mania. Same like in a depression patient, 2 or 3 questions of depression, you can always add in the MSE. That's a good thing, okay? Because you're mainly, you already know that what is the case all about.
Sure.
Apart from that, in MSE presentation, your appearance, you can say that obviously you can't see the patient now, but when you will see the patient, say the patient is very restless, because you could even understand that this patient was quite restless throughout the conversation. Then speech was a rapid, pressured speech. Then mood, you told that mood was good, not good. Say that patient says that her mood was very good, which was unusual for her. And the affect that I have observed, that's also congruent with her mood. So it's not good mood, it's actually hyper elevated mood, or like not a usual kind of mood. Okay, so good mood means that that's normal for a lot of people. Like sometimes if I say I'm having a good mood, that doesn't mean I'm having mania, right? So it's a hyper elevated mood. That's what patients with mania gets. Then thought form and thought content. Mania patient has flight of ideas. So in case of thought form, it's a good idea. Like obviously I was at first I was talking about, let's say, a spaceship. Then I talked about Elon Musk. Then I talked about getting a Nobel Prize. Then I talked about Jupiter. So I'm moving from one topic to another, jumping from one thing to another, having association a little bit between them. That's flight of ideas. Okay, so in mania, in thought form, say that if you get something like that, say that my patient was showing flight of ideas, but there was no loosening of association, tangentiality, or circumstantiality. In case of thought content, delusion of grandiosity was obviously there, and delusion of jealousy or persecution was there. Insight, you did not assess it. So say that now in exam, if you forget to assess insight, just say that I did not assess insight. Okay, just in that way. Or I forgot to assess insight. If you say that, they will never ever, like that's not the thing that will fail you. Okay, they are not angry because of that, but someone who did not assess insight, but rather say that insight was not intact, they will fail. So if you are true to yourself, then they usually like that. So you did that, that was good. So insight, then judgment, cognition, you said, and then 3R. This patient, you were able to maintain a good rapport. Patient is a moderate to high risk, and it is not a reliable history. All good? So that's all about this. Mania comes in exam as well, so make sure you know about this. Any question for anyone? Yes, Dr.
Zahra. Sir, in
Zara,
this
yes.
case, in this case, when patient is already telling that she's so high, not high, but she's feeling very good, and she like sky is beautiful, then do we need to ask about mood still or not?
No need. Because you are already getting the answer.
Yeah. So we don't need to mention it again and again.
No, that's fine.
I have a question, Dr. Harsh.
Yes. Yes.
So the first question is, would all the psychiatry cases be covered in this course?
Psychiatry cases, yes. Like just in today's class?
No, in all the 5 months course.
Yes. Yeah. We cover everything.
Sure. And the second question is, there are lots of different resources out there, such as Marwan notes and the recent recalls and the clinical handbook. So my question is, would the material in this course cover everything and we don't need to go to different resources if we just read the material that's given by you, or we also need to read other things as well?
No, that's a very interesting question. There is no limit of learning. That's the thing. Now, always like if a candidate wants to read a lot of other things, that's totally fine. But we normally give everything that you need for the exam, everything which is included for the exam. Obviously not the full handbook thing, because handbook is a totally separate book. You have to read it, obviously. But the cases which is important from handbook even, we do that in our classes. But obviously there are some unimportant cases which you just need to go through from the handbook at least once, just to know about it in case it comes. The 150 cases all are not important. Sure. All right, so most of the things will be discussed. But again, like there is always 10% thing which you might need to just find out. Right? Like there is no one who can say everything like 100% will be done, but I can say that at least 90 to 95% will be finished.
Thanks, Doctor.
Hi, Dr. Arshan, this is Huria. Yeah, I liked your class today. It was very informative. Just a quick question, because I've been booked for my exam that's going to be happening in 8 September. Given that I'm working also in a hospital, and I know I have like a very short time to prepare, and I am pretty much sure that I'm not going to cover everything and all aspect of it. But yeah, I'll try to like cover like most of it, and your classes are really helping me with that. But I'm just wondering that is there a possibility that I can just look into the previous videos also, just to cover up and to make up like, you know, the course?
Yeah, like have you got the exam date already?
Yes, it's 8th of September.
Yeah, so I think like we already told everyone about that. Like if anyone has got exam date, you already get our previous batch recording. You just need to give us the placement letter and we will add you to the previous batch and you can go through that in your own time.
But okay. I'm able to take your live classes on this session also.
Yes, okay. Obviously.
Yeah, I think I have emailed you, and also I think I'm going to send you through the Facebook also, if that's fine with you.
Yeah. Just send me an inbox about it. Say that your exam is on this date and this is the placement letter. Can you get added to the previous batch?
Yes, sure. Okay. Thank you.
And also remember that like anyone who like any of this new batch students, they are going to get we have at least 55 role play sessions so far. That's covering all the important cases for the last 2 years. And we have been doing role play for the last 2 years. So all the 2-year role play cases, which has been done role played as well as discussion, it's already in our software. So you will get those things immediately not immediately, after I think making your full payment, you will get all those videos in your software. So you can just go through that in your own time. And that is an amazing resource, trust me, because that is what will make you pass the exam as well. Okay, so you will get that. We have never done that before because we did not have this much resource to give, but now we have that resource. Now you will be the first batch students who is going to get all of those videos. And obviously, every week we take a role play session, which is done by Dr. Cynthia. She will also take one of the class in the free 2-week session. Have a look at how she's doing the classes. Everyone loves her, so I guess you will also love her. So obviously, she will take the role play sessions. I will take the role play sessions. So that is how it will going to happen. That is a 5-month course. Many of you might think that why 5-month course, because it might look a lot for many of you, but trust me, it is not a lot. Any beginner needs at least 2 to 3 months to even understand it. There is no one who can say that by 2 to 3 months, I'm going to appear the exam and I'm a beginner. A lot of people just write it in their feedback that I've just prepared for 3 months. That's maybe just their main preparation time where they actually read a lot, but obviously they had to prepare for at least 5, 6, or even 7 months. Clinical is not like a very small thing that you are going through. If you are working in an Australian hospital, yes, I can say that you might be able to even go for the exam with just some knowledge that you already have. But if you are not working here, and then it becomes really hard because you are learning everything as a new. The system is totally different than what you are doing in your country. So you have to give that time to pass the exam. And this is not like a very low cost exam. You are giving more than $3,000 for that exam, right? And you're not getting you can't just do a repeat exam like we used to do before, like with a smaller number of cases. That thing is no longer there. So you have to again reappear the exam if you fail it. So you have to be very well prepared if you are going for the exam at least. So that time is needed. When you finish our 5-month course, you will always find someone is there along with you. And you join the live sessions, you join our role play sessions, you don't feel alone, you don't get depressed. So that's why it is important. We could take a 3-month course, that's not a problem. That will be more beneficial for us. But we just do it because that's why the candidates pass from this course every month. A lot of candidates passing. There is a reason behind it. So trust me, the design of the course is maintained in a way that is best for you. And apart from the course, Dr. Anika, I would say that read your handbook, at least with your study partner. I would also advise that whatever we are finishing in the class, finish it with your study partner. Do the role play of those cases. All right. Some of the role play sessions, the cases will have no cluster. That's the random cases. So that random cases, you have to do it with your partner at least once or twice to get to understand that. Initially, random role play session looks very hard, but trust me that that's how the exam questions will come, because you will not know the cases. You'll be going into the exam and the new questions popping out, and you will be just shattered. So the role play sessions are going to help you to get that feeling that if a new question pop up in the exam, what you will do, what the feeling happens in your head. So that's why the random role play sessions, we do it every week. But everything you need for the exam, it's already in the course. There is nothing you need apart from it. And yes, you will always know the schedule of the topics before the sessions. It's already like the candidates who are joined in the course, they already know the session. Just like you have got a schedule of the topics in your Facebook group, the 2 weeks free sessions, that will be always done in your course as well. So you will know what classes we are taking, when we are taking, the schedule are there. And we will discuss about claiming the CPD course, like how you can claim the CPD hours from the course in detail in one of the class. Like 8th July, we are going to have our a career guideline session. So we'll discuss about that at that time. Okay. So that's all about today. So I hope that you guys enjoyed the session. If you have any questions, anything that you want to know about the course, about the exam, about your preparation, don't forget to at least email us or inbox me. Okay? And always you can ask it during this 2-week session, just like you are doing now. And the detail of the course is already in your Facebook group, which is the First Aid AMC Clinical. So just go through the details. And even if there is anything after that, just ask me. It should be fine. Thank you, everyone. Have a good night. Bye. We'll see you in the next class. And next class will be on cardiology. Thank you.
Darshan.
Thank you.
Thank you, doctor.
Thank you so much.